Good morning, everybody. And we're talking about the cuff today. The reason why we're talking about cuff is that probably I'm now soon going to be out of the bracket. I'm already out of the bracket where I'm in no tear, and probably getting into the bracket where I'll be a unilateral tear very soon. So I think cuff tears are probably the most common treated shoulder pathology in our clinical practice. We have a large amount of outcome data, which is what you'll hear in the next day and a half. We have a large amount of appropriate surgical indications, but still the controversy still exists. So I'm here to talk today as to do all cuff tears really require repair. These are my disclaimers. I am a surgeon, I'm not a physical therapist. So probably I'm not the best person to be qualified to be giving a non-surgical talk as well. I'm not here to sell you the red pill or the blue pill, like what Morpheus hands over to during the Matrix. So I think it's a balanced decision. Very interesting discussion that we had, just a couple of minutes ago. And the reason why we need to discuss at times which tears really require a repair is because we still do not completely understand how healing occurs, how our repair will fail, how can we improve our healing rates, and what will affect our outcome if we were to repair, and which is the reason why some tears still are amenable for good non-surgical treatment. So this is about 2 decades ago where Ken Yamaguchi published, where he had indications and timings sorted out based on groups. We had the initial non-operative group, which were all the smaller tears and the partial thickness tears. We had the early repair group, which were essentially all acute traumatic tears and all failed conserved tears, which were larger than 1 centimeter. And again, we had a group 3, which were the initial non-operative treatment type of tears, which were all chronic tears, especially in people who are more than 65 and irreparable tears. This, I think, was subsequently modified by Robert Tasjian. I think this got published about 10 years later. And essentially, this the talk, which tears can be conserved, probably will be based a bit on his philosophy, which still holds true, if not 100%, at least gives us good guidelines and algorithms for clinical practice. So tears probably whom you do not want to operate upon would those be who have got simple tendonitis, those who are partial thickness tears, especially, except possibly large bursal-sided tears. And this is probably a similar image to what we were discussing a couple of minutes ago, where you have this signal and a small footplate tear, which, if it progresses, then of course it is amenable for a repair. But if not, then I think these are the ones that could be initially treated non-operatively. And of course, small full thickness tears which are less than 1 centimeter, which have a preserved cable, are the ones that could be treated and should be opted for non-operative treatment. We have the group 2, which are early operative tears. These are all acute tears which happen especially in younger patients and in middle-aged patients above 65, and which may present with acute pseudoparalysis. And these are the tears which will definitely require early operative treatment, because if you get to them late, then probably you might miss out on the chance of doing a good job on them. Also in this group, one would want to consider chronic tears in patients who are less than 65 years of old, because whatever data that we have and outcomes that we have does support that these tears, which are larger than 1 centimeter, will progress over a period of time. And if they keep on progressing, then the outcomes following repair will drop drastically, and more tendons may get involved with the traction, and then this leads to poorer outcomes. The third group, which is probably what we see more often, is the one that probably should be tackled non-operatively initially, and then a change in plan should be made as we follow up our patients, because probably they are not doing as well as what they want to be. What would be constituted in this group would be probably all chronic tears, especially in patients who are above the age of 65. And he also mentioned irreparable tears to be the ones that are to be treated initially. What is important now is that these type 2 of the group 3 are now the tears that we can now treat more better with the help of tendon transfer techniques, or near improved of using dermal patches and so on and so forth. And definitely we would see some change in how we approach this group 3 type 2 by modifying our treatment plan in a certain manner, and this is something that you would want to definitely pick up over the next day and a half. What is interesting to understand and note is, which Mukesh also showed, is that you have these tears which are grossly irreparable tears, but they have excellent function, and that is the reason why every patient will not always follow the algorithms that are published in clinical literature, and there is something definitely that is more than all of this. So we do understand that at least 2/3 of the hair tears will completely heal. I'm talking about larger tears. Smaller tears, almost 80-85% of them will heal, but we still struggle with healing of large massive tears, especially in the elderly people. So the current literature that we have today on healing focuses a lot on the surgical technique, and this is what we'll be discussing in the next day. But what we need to understand when we choose our patient to operate or not to operate is to look at certain factors which will definitely change the healing. And these will include surgeon factors, the biology of the disease, what sort of rehab protocol that you're looking at, and some obviously environmental factors like smoking and medication, which will influence the amount of healing, which will then prompt you to make an appropriate decision. So definitely biology probably would be the most important factor, especially for older patients and larger tears. We are not going to be talking about traumatic tears. We are not going to be talking about subscap tears, because these two categories behave completely differently. So probably about 50% of all your asymptomatic tears will get symptomatic over a period of time, approximately 3 years, and about 40% will progress with increase in the amount of fatty degeneration and progressively tear which is there. So age is definitely an important predictor of which person you want to allocate towards surgical or non-surgical treatment, and unilateral tears are the ones which will especially occur in the younger patients, and these are the ones that you want to reach to. Smokers and people who are on drugs and diabetics and thyroid patients who have multiple steroid injections probably will have a slower healing response, and those need to be exercised definitely with caution. So how do you optimize your results? You choose the correct patient. Now younger patients with smaller tears, I think more towards surgical, because biology is favorable, and in these patients the skill of the surgeon probably may be the more important aspect in determining the healing of a tear. As against in an older patient with a larger tear, probably biology is not favorable, and even the best skilled surgeon may not be the deciding factor in the outcome, and probably what we are looking here is to change him from having a symptomatic cuff tear to an asymptomatic cuff that is repaired. So which tear should we repair? So I think acute traumatic tears with change in function, we need to repair them. Failed non-operative degenerative tears which are fixable definitely have to be repaired. Symptomatic partial tears that have failed your conservative treatment need to be repaired. And I think probably a young patient with idiopathic tear, we see them because we do get the odd patient who's had a couple of steroid injections, is the one that we need to repair them. Then the question is that what if we don't repair them? Well, if it needs to be repaired and you don't fix them, what is going to happen? If you look at all the natural history data, you'll see that an asymptomatic tear will become symptomatic, especially in the young active patient. It may progress and worsen, and if the patient is older, then it will probably not heal reliably. If you repair them, then almost over 85% of them will have good pain relief and will have good functional and strength recovery, because healing directly correlates to function, which correlates to improved quality of life. So take home points would be that which are the tears that you should and should not repair. You should look at all these options depending upon the tear size, age of the patient, smoking status, etc. And utilizing such algorithms will definitely help you in understanding which are the patients that you want to get to early, which are the ones that you want to treat non-operatively initially. And it's always a good idea to look at these 3 W's. Who is your patient? What type or which type tear are you looking at? And what is your treatment goal? So look at who is your patient. These are the ones that you want to probably look at more surgical treatment. Which type of tear do we have? We have almost about 18 possibilities if you go across the grid here. And what are your goals is what will determine, achieve your treatment plan. Thank you very much.